stream now started? Yeah, so just to make everyone aware, the meeting is now being live streamed. So good morning everyone and welcome to this meeting of the Health Scrutiny Committee, which as I say is being broadcast. We'll move to our first agenda item, which is to note the appointment of myself, Councillor Robertson, as Chair of the Health Scrutiny Committee, and Councillor Jim Vernon as Vice Chair of the Health Scrutiny Committee at the full Council on the 14th of May. Thank you. Item number 2 is to note the membership of the Health Scrutiny Committee for the 2026-27 municipal year, which is as follows. Councillors Christopher Adegoke, Councillor Janette Barlow, Councillor Alan Byte, Councillor Terry Cox, Councillor Kev Dale, Councillor Dr John Doddy, Councillor Helen Faccio, Councillor Roger Upton and Councillor Jonathan Wheeler. Thank you. Moving on to item number 3, minutes of the last meeting held on the 14th of April 2026. I assume everybody received a copy in advance of the meeting. And can I accept these minutes as a true and correct record of the meeting? Yeah, thank you very much. We'll now move on to item 4, apologies for absence. James, do we have any apologies?
Thank you, Chair. We have received apologies from Councillors Christopher Adegoke, Councillor Dr John Doddy, and Councillor Terry Cox, all on the business. And today we have Councillor Russell Dodd as the substitute, Councillor Pepper as the substitute, and Councillor Jason Rich as the substitute. Thank you.
Thank you, James. Moving on to item 5, declarations of interest. So may I ask, do any members present have any disclosable pecuniary interests to declare? No. And do any members present have any private interests, pecuniary or non-pecuniary, to declare? No. Thank you very much. So now we get into the actual business of the meeting. So we move on to item 6, which is a dentistry update. So this item is for consideration is a report from the Integrated Care Board across Nottingham and Nottinghamshire, Derby and Derbyshire and Lincolnshire. And I would like to welcome this morning Catriona Peterson, who is the Associate Medical Director, and Vanessa Hales, who's the Head of Primary Care Services. So could I invite one or both of you to start your presentation? Thank you.
Thank you very much for inviting me and stepping between us today. I have produced a short presentation to complement the paper that we sent through. So just to chat through, the aim is to provide an update on NHS dental services in Nottinghamshire, summarise the work that we are doing in the team to improve access, the challenges that we're facing, and our commissioning priorities for this financial year. Oral health is so important and is so fundamental to overall health and well-being. Poor oral health leads to pain, infection, and avoidable hospital admissions. Oral inequalities closely mirror wider social inequalities. And prevention and improving access to NHS dentistry is a key strategic priority for our cluster. So where are we at the moment? Well, dentistry remains challenged. There are approximately 2,700 NHS dentists, national shortage of just over 2,700 NHS dentists. Recruitment and retention remains challenged, and we are very much tied by the historic NHS contract, of which I provided a bit more detail in the paper. Within Nottinghamshire, we have 159 NHS dental contracts, and services are delivered in a combination of ways: primary care to your high street dentist, community and specialist services. Most residents within Nottinghamshire live within 4 miles of dental practice, although access does remain variable. So the good news is that Nottinghamshire continues to perform above the national average, which is 30.14% of the population of accessing NHS dental care. So that is good news. Other good news is that dental activity has increased. We only had one dental contract handed back in 25-26, and 83,000 units of dental activity have been recovered from providers to reinvest within the system. As I previously mentioned, there are challenges within the NHS dentistry. The historical contract that we have to work to, there is unequal access across districts. There's higher oral health needs in deprived communities. Waiting lists are high within secondary care, and we're continuing to see an increase in demand for urgent dental appointments. The three ICBs, Derby and Derbyshire, Lincolnshire and Nottinghamshire, have put together to form one cluster, and we have a 26-27 dental commissioning plan, which details the actions that we're undertaking each quarter and the metrics that we're going to be using to measure our progress. To summarise what we have undertaken within quarter one, it's to complete the procurements that commenced last financial year, commission up to 110% activity, redistribute recovered UDAs. I appreciate both of those. It's, if you want me to take you through what that means later on, we'll have to do that in the presentation. Target investment to areas of greatest need and develop services for vulnerable groups. So our objectives as a cluster is to improve access to NHS dentistry, reduce health inequalities, improve prevention. We want to maximise the existing workforce. We don't want any more dentists leaving the NHS to focus on private work. We want sustainable services and improve patient outcomes. So just to conclude, oral health remains a significant public health issue. Nottinghamshire is performing above the national average, which is good news, and activity and patient access is continuing to improve. I have mentioned the workforce challenges and the historic contract arrangements. And we have a commissioning plan, which is a clear programme to improve access and reduce inequalities. Thank you. Would you like me just to explain the 10% of your covered UDAs?
Yes, please, if you could. Yeah.
So, what 110% means, a dentist is contracted to deliver a certain number of UDAs, which is units of dental activity, and that's how they are paid. A dentist needs to be delivering 96% of their contract, and they can't go over 96%, that's the threshold, unless they've got permission from the ICB. So we have implemented a scheme where we've invited providers to come forward and say, can you deliver 110% and we will pay you to deliver 110%. And that scheme is just out for providers to accept. It went out this week. So it's one way of increasing activity. Redistributing the covered UDAs. Okay, what this means is, as I said, a provider, for example, a provider is contracted to deliver 10,000 UDAs. Say year one they deliver 7,000, year two they deliver 8,000, year three they deliver 7,000, but their contract is 10,000. After 3 years of underperformance, we can say to them, right, your contract's 10,000, we're paying you for 10,000, but you deliver 7 and 8 and 7. can we have a conversation with you about reducing your contract to 7? Because that's what it seems to me that you are delivering. The difference between the 7 and the 10,000, we then say we're going to take that and we're going to put it off it to providers who are able to do more. So that's what the redistribution becomes UDAs mean. And we've just started that process this week for reissuing the UDAs that we've recovered from providers who are underperforming. And I learned very quickly that dentistry is quite complex, much more complex than the general practice that I came from. Their payment scheme is quite a bit well understand.
No, thank you very much for the presentation and also that further clarification at the end. I will now then open up the discussion. So, any members who wish to? No, Councillor Upton.
Thank you, and thank you for that report. I don't pretend to be an expert on dentistry, and I think you just said it's a complex area. Having read the report and from personal experience, yes, it is. I've got a couple of comments, stroke questions. I think you referred to the historical contract, which might be historical, but presumably it's still live and active. I don't really understand what's happening about the historical contract, because to me, that seems to be the root of some of the issues you're discussing. So a bit more info, if I could, on the historical contract, where it is and where it's likely to go. Thank you for clarifying what UDAs are, units of dental activity. And I suppose I don't really understand, the word's correct, the disconnect, if you like, between public NHS and private practice, because I see that in all health across the piece, really. NHS at the QMC and hospitals is a world of consultants and doctors and the like that have one foot in the public, one in the private. Yet dentistry seems to be a completely different, confusing world to me, where it's almost an either or. I was with an NHS practice until 20 years ago, and instantly, we're not doing it anymore, you can either stay or go. There's the door. So I stayed, and then I said to them, and it's in this report, and I think if you could answer the question, these UDAs and the number of treatments that they do in a year, I was going every 6 months with such good, comparatively good team, and I said to them, I don't want to come every 6 months. People don't look at my heart, my brain, or any other bits of my body every 6 months. If ever, I'm not coming. I'll come once a year. And after a great debate, they said, well, all right, once a year it is. So fine, the customer is always right. Answer I use. So if I can get by once a year, surely a whole load of these UDAs are clogging the system up because the dentist is having to see them every 6 months. I just think, is there some work you could do there to renegotiate your historical contract to say you don't have to see everybody every 6 months? That's just getting the statistics up to get the money in your hand. I'll stop there. It's a confusing world. I get it. But I think there's some big issues there. The historical contract, the units of UDAs, why would I go every 6 months? Why does most of the public? It says in here, I think, it's an easy win-win for them. Because the statistics, they're easy to see people with no problem every 6 months. But you score on the statistics and you get your money. I'll stop.
I'll try and come back and respond if that's okay. So the historical contract is a national contract, so you can't actually affect the contract the practices have, which was put in place in 2006. Nationally, they are making changes to it. The reason your practice probably stepped out of the NHS in 2006, which you said was 20 years ago, that's exactly what they did. Yeah. Because they, at that point, saw the new contract that was coming in and didn't want to work in it because it was so bad. So they took the option of going privately. And luckily, you stayed with them as a patient. So then that meant they were happy, they were still getting paid for it. Others chose to stay in the NHS for whatever reason, and have stuck with there, and it's been hard work, but they support the NHS, and they chose to do that because the population needs the NHS. Up until probably just before COVID, there was very little change in contract. That gave COVID, I think, gave people the opportunity to consider what they wanted to do going forward, and more have left the NHS. There was a whole raft of people who left the NHS after COVID, which why I became social. The UDAs are targets that they have to make every year to get paid. They're actually paid in advance. If they don't meet their targets, their money that they've already been paid is taken back off them. So if they've paid their staff, the person who owns that business is in trouble, aren't they, if they've had the money taken back off them. The original contract, if you did one filling, you got paid a band 2 fee, which was about £50. If you did 10 fillings, you still only got paid that £50. So you was buy one and get 9 free from the patient point of view, but the practice had to do all that work for the same amount of money. And nobody else would do it in any other business. The patients don't understand it because previously you went in, you needed 2 fillings, I'll have 2 fillings and that would be twice the price of one. It was only after, as I said, after COVID, the change of the chief dental officer. So we had a new chief dental officer come in place who's actually based in Lincolnshire and has worked in Midlands as a dentist for years. Prior to that, the chief dental officers were from the military, which has nothing to do with the contract, so there was no appetite for change. He started to make changes to the contract, a bit like since it was put in place in 2006, there have been numerous attempts to come up with a better option. The better option would cost the government a lot more money because it was basically a salaried service, and that's why they originally put in this cap in this contract. So it's all about trying to limit the amount of money the government has to spend on NHS dentistry. So changes have been put in place. There's some that are just coming in currently. They're not, the contract is still basically the same, but there are things put in. If you do 3 fillings, you get paid more than if you do 2 fillings. Is in there now. So there are some changes in it, but it's still the basis of it is that there's a lot of 20 years of bad feeling from the contract, which has never been, and a lot of people have walked away recently, which is where the workforce issues came into place, along with other things. As you said, you can run a practice, NHS and private, you can see them on the same patient, you don't have to, it's not a case of, some people choose to go completely private, some people work in both systems, and some people still work in the NHS, and that's what they offer. It isn't an either or, but it isn't like any other system in the NHS, because those dentists own their own practices, they pay their own staff, whereas a consultant in a hospital isn't responsible for everything that they have to pay for. You're right about the every 6 months. It does clog up the system. You didn't need it. A lot of people don't need it. A lot of people feel they should have it because it's their right, because they're in the dentist. And they also are worried that if they don't go every 6 months, they may not have a place when they do need to go, which of course after COVID was very much the case, because there were a lot of people who hadn't been for a while because of the situation in the country at the time, and they when they did next go back to their dentist, the dentist had gone private and said, not been for 2 years, we don't have to offer you an NHS appointment, but you can have a private one instead. And that was how they converted to private. So it's changing the mindset of the patients as much as changing the mindset of the practices. There are some people who really, really do need to go every 3 months or 6 months as well, which obviously complicates it. It's not the benefit thing. Hopefully, I haven't taken up too much time explaining.
Oh, thank you.
Yeah, Paul, Councillor Upton, was that okay? Yeah. Councillor Vernon?
Yeah, thank you. We paid them for 110%, or do we pay for 90%? That was their target.
Their target is 100%. If they make between 96 and 100%, they don't get clawback. If they don't make 96%, they get clawback. They can, if we have money in the coffers to do it, pay them extra to do an extra 10%. But obviously, we're only going to offer that to the people who can do it. There are some who only ever make 80%, so then we're not going to pay them extra for that.
And on the flex, let's just say someone's underperforming, as you said, and he's so many thousand of UDAs short.
Yeah.
And you say, right, you'll take them off him and you'll redistribute them. How does that work?
So we read as a contract. They have to have underperformed.
Sorry, within a time and financial point of view, I mean, you can't just pick up 10,000, if you like, places to get your teeth done and throw them, say, in the north of the county.
It's not patients.
It's teeth.
Well, it's not teeth because units of dental activity, patients aren't registered with an NHS dentist. If they're not performing those UDAs in the first place, they're not seeing.
Or UDA, there isn't somebody sat in the chair necessarily.
No, well, that's the whole point. If they're not doing them in the first place, that's because they're not seeing enough NHS patients. So we're saying over here, this practice has a big waiting list for patients. You've not got a waiting list. You're just seeing people and you're doing all your private work in your chair time. So that patient's sitting there to private, you're not doing the NHS. So we're going to take those UDAs away and give them to somebody who wants them. We don't force them on them. We ask for expressions of, capacity and things.
I'm a little confused because you say it's not a patient, to me it is. You either
It's a
give
private patient then.
Yeah, right.
Yeah. So it's not an NHS patient sitting there because they're not delivering their NHS capacity. So we're saying, let's have it. But up until last year, we weren't allowed to do that. It wasn't in the flexibility of the contract to allow us to do it, and that's one of the changes that's come in.
So, and sorry to hold these, it's the same question, I'm just getting my head around it. So we move 1,000 from this practice to this practice. Okay. What's that look like in timescale? I mean, because you're reviewing it quarterly, so at the end of the quarter, you realise this guy isn't going to make his target.
No. So we look at 3 years of data for the practices who are underperforming. We then have conversations with them and say, you're underperforming, you have underperformed for 3 years, and even before that, 3 years is when it came in, we had to start doing it. Those UDAs are then moved away, they've lost them, they don't come back to them, they've lost them, they've had their chance. They knew 2 years ago that if they didn't manage to reach the capacity, they would lose them. They've lost them, they go somewhere else permanently, and it's up to that person to achieve them. That person is also under scrutiny, so if we find all of a sudden that they can't do the extra, we'd have to give them 3 years to do it. If they can't, then they'll be moved on again. Some people want to do it, but they can't get the workforce to do it. So some people will say, yeah, we want them, we'll take them. But it can take them a while to actually find a dentist who wants to work in the NHS to do them.
Thank you for the answer. Thank you, Chair. That drifted a little bit. Sorry.
Councillor Faccio?
Hi. So I've just got a question first to clarify what Councillor Upton said. Are you saying that dentists who see patients every 6 months, so patients have good teeth, that isn't necessary, and that depriving other people of having appointments. And if that is the case, has NHS guidance changed on people going to the dentist every 6 months?
The NICE guidelines actually came in quite a number of years ago, which actually said that. It's a clinical opinion of the dentist as to how often that patient, based on their needs and their level health and their age and their medical health, all kinds of things. But yeah, there are patients who are seen unnecessarily. And of course, they're also being charged to be seen. So most patients are actually quite grateful if their dentist says we don't need to see you every 6 months. We'll see you once a year. You're still one of our, you're still on our list and everything. Take you this Monday. If you need to come in between times, so break a tooth, you can come, just phone us up and we'll fit you in. That's all there. But some practices prefer to just see them. And over the years, I'm trying to think when I first had that discussion with a practice, and there was a local practice to here who actually said they only look after their teeth if they know they're coming to see me every 6 months. So I need to see them every 6 months, and then every time I see them, their teeth are really good. So the guidance changed a number of years ago. People were reluctant they were taking the easy option, basically. But the things have got tighter now. So hopefully more people will take up the recommendation of NICE guidance.
So my question, I know you said that Nottinghamshire is over the national average of people accessing dentists. It still seems really low when it's less than a third. What is the targets that you have in mind of how many people should be able to access a dentist, like a realistic target for the next 5 years? And also your areas of priority basically lists every district in the county. So are there areas that are more of a priority than others in order to have NHS dentist access? And I ask this bearing in mind that in Eastern there was a new dental practice that opened, and it said, I don't want to talk about a specific case because I know about the details, but the story that came out was that they asked for an NHS contact and they weren't allowed one, they weren't given one. And I know that a lot of people in Eastern and the wider area who don't access an NHS dentist, there aren't any accepted patients in the area. And that caused a bit of a local uproar because people don't understand why a dentist is asking to have NHS patients and not being allowed them, and there are people that do want an NHS dentist.
So this goes back to the national contract. We can't just, and we never have been since 2006, been able to just open up a new practice within the UDAs. There were never more UDAs than there were in the first place, so we're still working with that target figure. So if we give some, we have to take to something else. We are in our commissioning plans intending to open a new dental practice in each of the ICD areas in the cluster, but that is something for the future because if we have to go out to full procurement, because it's a new service that we'll have to take it through governance and obviously find the money to do it. And it could be a big expenditure because it would have to be forever to bring it to line to anyone else. So we're talking about a big investment and commitment. And the biggest problem is where do you put it? Because actually your practice isn't going to solve the problems. We're working on trying to get the UDAs that haven't been used out of practices that will have used them and actually do that in all the areas that need. We've also got other plans to target areas in high need, which are the hardest ones to get dentists to work successfully in the midst of the high need.
Do you have a target of percentage of people who can access?
So I know I haven't got the actual figure, but I've got a figure that I think it is that the NHS has never funded 100% of the population to have NHS dentistry. I think it has been certainly less than 50% in the past. It varies, it's higher for children. So we have identified the figures as every area has now, and we would like to increase all of them by, I think it's 10% of what they are over the next, however long it takes. That's the first step. And still, it's not, it's not, I know that the national levels are low, so although we're better than national, it's not really something to be proud of, is it? But we are working on it, we're not resting on our arms. And we think the changes in the national contract as well will make a difference as well.
I'm going to come to you in a second, Councillor, with that. I've just got a very quick question that came off the back of Councillor Faccio. So if I understand this correctly, what you just said there, Catriona, is that the UDA number doesn't change. If you bring a new practice in, then it's about taking off somebody else if you're going to redistribute. So is the amount of UDA stayed the same since 2006?
Yes.
Right, okay. I just wanted to clarify that.
Yeah.
So it is.
So once you sort of hear more and more about it, you start to understand what the problems are with,
Yes.
with the NHS.
Yeah. So a new dental practice in itself would not necessarily solve the issue because of the amount of UDAs.
The ICB are investing, so it will be new money into that. But all the changes, even the national changes in the contract, no new money has been put into dentistry yet since 2006.
Right, okay. Yeah, absolutely.
110% scheme that we mentioned, it's an annual scheme which is not included funding. The UDA redistribution is recurrent funding, that's within the pot.
No, thank you very much for those clarification. Councillor Wheeler?
Yeah, thanks, Sharon. I've got a couple of points. I think first of all, to say thank you for the way you're answering these questions in real world, and it's very refreshing to have a proper conversation. I can tell you're just as straight as we are about this contract. I can imagine you must get from a lot of you guys it's something out of your control. I mean, first of all, you know what lobbying and what's been done by ICB Section 2 government on this? Because 3 different governments over 20 years, and this is the same. We know the contract seems now. And what has been in feedback from government in terms of the Department of Health about what they're looking to change this, because if someone like me, and I'm sure you might have seen under everyone else, thinks this is a great situation like this in 20 years. And as far as officials pay a lot more than we are, especially not smarter than we are, can't see that as well. And one other thing is what UDA, etc. So in Rushdale and across Nottinghamshire, with a lot of extra housing, obviously, and part of the application stage, we're asked for to put forward for primary care spaces in which GP place, etc. I'm wondering in terms of why we don't ask for extra dentistry. I'm assuming that the UDA is that's the main reason why we can't. So again, there's something to look at in terms of that volume changes of planning regulation for that, because it seems mad that again, I can't afford dentistry in Rushdale in the last few years. I've definitely not run around my area yet. I've had an extra 10,000 houses, so the extra demand going on with no extra. That's something we wouldn't accept that for doctors, we wouldn't accept that for school places, yet we accept that for dentists. We as society are there. So we just know what your bill is and what work is potentially being done to go involve MPs, etc. to government to look to get changed. Thank you.
So there has been a lot of government lobbying, a lot of most of the MPs are very vocal about it. We got some changes this place with the 700,000 urgent care appointments, but then extra money came with it. So we had to adjust the and it was we have got slack in the thing because people aren't performing on their contracts. So we have to, we found the money when we paid it, and practices have delivered on their urgent care. And it's the same with the housing. There's no extra money. So there's no extra money. We can, because we've got slack, because we've got these people that are moving out of the NHS. But actually what we want to do is stop them moving out of the NHS as well. So to try and support them to do more work. Yeah, it's frustrating and it's a common question. We all have houses and houses being built around us, and presumably those was it just offer a private dental service instead, and they don't need to see as many patients because obviously they make more money out of smaller cohorts. So probably there are certainly people around who will pay privately because that's their only option. They either have to or they feel that's sort of thing. Because the NHS gets so bad press as well, which is so yeah, it's very frustrating. I haven't really got any answers, but we're trying.
No, I can see that now, thank you.
Councillor Barlow?
Yes, good morning, thank you. Yes, I do appreciate your sort of honest and clear answers. So I'm a great believer in, prevention is better than cure. So I'm looking at what we're doing around child's oral health. It's very good going into schools, teaching them more how to clean the teeth, and that's great. We also talk about inequalities. Now, obviously, we know that children are learning how to brush their teeth at school, but what about when you get home? So whatever happened to school dentists, at least you know then that there is some equality, that all children then access a dentist from a young age, because obviously teeth are important, we know that. We live in a social media world where everybody's got to look perfect, and teeth are a big part of that. So is there no chance of bringing back school dentists to make sure there is that equality with children's oral health?
I think that school dentistry now is a lot more complicated than it used to be because of consent processes. The school dentist used to turn up in their van and park up, and everyone saw the dentist, and then you used to get a note to say Helen's doing or whatever. Now, when we've tried to go into schools, and this is not for treatment, this is just for a lot of people, and you can imagine it's different in different areas and different schools. There isn't buy-in from the parents, so they don't actually sign the consent form, therefore that child can't be seen. So it almost widens inequalities again, because the ones that do, and the ones that don't. Which again is really, really frustrating. That you can't get parents to go to something. And even now, there's a lot of them who just say, well, I don't bring them because there isn't a dentist. Well, there is a dentist if you need your children abroad to see a dentist. So people don't. A lot of it is people don't like going to the dentist themselves, so they don't see the prevention as being positive. They see it as a negative, but it's not a nice experience. Whereas if you go early enough, it doesn't have to be a bad experience. So I don't think, and again, there is a community dental service, which is what the school dentistry used to be part of, but that is more specialised, and it's for vulnerable patients or patients who can't go to a high street dentist. The children who can go to a high street dentist should be going to a high street dentist, and they're the people that can have 3 months if they need to, if they've got 4 months to do it. So, and there is available.
I now have Catherine's email address. We were asked a very similar question at this time I had with the colleague in dental public health, and she referenced a report which I'll get hold of and I'll send to you, Catherine, if that's okay. And she was saying that there wasn't actually evidence base that having a school dentist improved care, because parents thought that their child was being seen, whereas they weren't having the treatment they needed, they were just being examined by a dentist. Now, I don't want to go into the details of that report because I'm doing it from memory, but if I may send that to you, and I'll get a response from our public health colleagues, if that's okay.
That'd be fantastic, thank you.
So can I ask then, obviously, if we have this inequality, and it's not because parents aren't necessarily agreeing with the child's in a dentist, how are you going to overcome that?
I think it's just like a general education for the public, parents as part of that. You can't make them, can you?
That is exactly the point I'm trying to make. Is there I know there are some inequalities, but obviously, at the end of the day, it's down to parents.
We have piloted in Leicestershire, if I remember rightly, a scheme for vulnerable patients, which we are, based on the learning of that scheme, we're going to look to implement within our cluster. I can send some more details of that within the email as well.
Thank you. I'm now going to bring Sabrina in. So I don't know whether you've met Sabrina before, but Sabrina's the chief exec of Nottingham and Nottinghamshire Health Watch. So a colleague of ours. So I'm going to invite her to ask some questions.
Thank you, Chair. I just wanted to go back to that clarification question about targets for access, because that Health Watch was one of the biggest things that we hear about people contact us about not being able to get access to the dentist. And so reading through the report, seeing that the access rates is above average, which is a low average anyway, which means that over 7% of people still aren't accessing. So I'm curious, can you clarify, you're saying that you don't have targets but your own local targets to be able to ensure that vulnerable areas or vulnerable groups aren't getting access to dentistry?
We do, it's with your consultancy dental public health, of which I'm not. So I didn't want to say.
Sorry.
Sorry.
Yeah.
Sorry. We do have figures, but they sit with the consultancy dental public health, of which I'm not one of.
And ICB itself doesn't have the same.
Yes. But not with us today.
Oh, okay. So there are some.
Yeah, there's figures. It's just that I didn't want to make some figures up.
Absolutely. Okay. And then,
Having worked in the NHS for many years within different departments.
I'm sorry, just needs a microphone.
And so having worked as an NHS manager in many different departments for 25 years, every department I've been in is very much target driven. In the NHS and dentistry, it's very different. We don't have those targets. The only target that we had to achieve last year was commissioning 700,000 dental appointments. So this year we have set our own commissioning plan, but they are based on the national measures.
okay. And the other thing you talked about was the vulnerable scheme for vulnerable patients. Is that correct? And that they will be rolling out.
Based on the learning, we're piloting it in Leicestershire at the moment, and that's working with on memory food banks. I will send some further information, but we're going to be looking at how that is being implemented within Leicestershire. If it's positive and if it's learning, we'll be rolling that out within this cluster.
Right, I see. So in terms of Nottinghamshire residents, I read in the report that there will be scheme we're rolling out in Q4, is that correct?
Yeah, based on the learning of the pilot, yeah. If the pilot isn't successful, we'll have to look to do something different, but we are committed to doing a scheme for vulnerable patients.
Okay, will there be any engagement with those vulnerable patients to understand how they're experiencing that side of it?
One of our commissioning principles is engagement with both professions and with the patients that we have.
Any other members? No? Okay. As I usually do, I always leave my questions to the last. A couple of things. So I'll probably go within the report first. So Councillor Faccio actually highlighted this earlier, that in section 7, which is about dental contract handbacks and rebasing, there's the paragraph that talks about the district priority order for increasing primary care dental services. Now, I assume, given that it's a bullet point list, top of the tree is the highest priority, and then we work down the list. Yeah. So we're looking at Ashfield and Mansfield as top, then the district of Rushcliffe, Broxton and Newark, and then we come on to my area, which is Bassett Law. But it then breaks Bassett Law down, particularly covering Woodbeck, Treswell, Cotham, South Leverton, which are all the Tuxford division. Now, I bore members to death with the fact that I represent the rural north, the rural northeast of the county. And if you then flip back to section 3, paragraph 2, and I'll try and paraphrase this, but ultimately it says that in Nottinghamshire, most residents live within 4 miles of dental practice, suggesting regional geographical coverage, however, not necessarily translate, where practices are not accepting AHPS patients, and some rural areas, my ears get pricked up there, particularly in the northeast of the county and parts of Bassett Law. Well, the northeast of the county is Bassett Law, and they have limited provision. Dental practices are mainly located in areas of high population density in the west of the county. High population density, I would assume, would be Ashfield and Mansfield, which are also in the west of the county. So your report suggests that the priority need is one thing, but another part of your report suggests that the northeast of the county, my part of the county, Bassett Law, is probably in greater need. So there seems to be a degree of conflict within the report as to where the priority is. And I'll just summarise with that. In my division, we do not have a single dentist, private or NHS provider. So a lot of my residents and family members have to go into South Yorkshire or into Lincolnshire to access care. And recently my partner had to go all the way to the north of Doncaster to get an appointment for an emergency appointment. So how can you guarantee or assure me, I suppose, that this priority order does actually reflect needs? Because I don't anecdotally think that it does.
I think probably we need to take that away and look at it. I'm wondering whether the fact that they step into an area which isn't in our area, that actually is skewing the access. And actually they have access, but it's over there rather than here. So it's okay if we take that away and come back.
Yeah, absolutely. And I think that's the power of this committee sometimes, is when you get areas such as I know Councillor Barlow, she's got a cross-border area as well. And there does sometimes tend to be skews in figures because our residents do go to other areas because of where they can access services. So yeah, if you could take that away and feedback, then that'd be fantastic. And I know in your presentation you talked about there was only one dental contract handed back. What was the reason for that contract, and does it reflect any trend on?
I need to check that.
So could be workforce, okay. And does that reflect a trend in contracts being handed back, or is handing back contracts more of an anomaly than a regularity?
I think that's nearly 2 years now. I think it's been across the East Midlands. It's not a frequent thing, is it? It's a very big couple.
So there were quite a number after COVID. As I said earlier, people made the decision to step out. It's a really big financial hit to hand back a contract. So they don't do it lightly. But if they can't get a workforce to deliver on the contract, then over time, they will then make a decision, and they'll have worked privately and sort of done a switch over. We haven't had, it's huge. We were, 2 years after COVID, we were probably seeing 4, 5 a year handbacks, but it's decreased. So, and I think in the other areas of East Midlands, I don't think we've had any in the last year. So it's sort of really come down now. So I think things have stabilised. We just need to try and turn them back round again and get them back delivering is our plan.
I I think that the last question from me, it comes from a very layman's position, because I never use a dentist. I'll be quite open about that. I avoid them. And I believe I don't need to see them. It goes to Councillor Upton's point that I don't want to fill a chair for however long a checkup would be when I know I don't have a dental problem. I think somebody else could have it. But I am aware that obviously we have dental hygienists who look after more of the oral health side of life. Now, do sort of visits to see a hygienist, do they count as a UDA for a dental practice, or do you have to actually see a dentist?
They do count, as long as that hygienist you're seeing is working in the NHS under a contract of the practice. So a lot of hygienists, more traditionally, now less so, are working privately. So you will have a checkup with a dentist and pay for that. You could have a clean and polish, scale and polish in that checkup, but it has to be clinically necessary. If it's not clinically necessary, but people like it because it makes their teeth feel clean and good, that's done on a private basis and wouldn't attract a UDA. As part of the contract, the checkup, if you have a checkup and a scan polish by the dentist or all part of it, it's only one UDA anyway, and they get that anyway for doing the checkup. So again, it's one of the anomalies of the dental contract. Band 1 is one UDA, and it can encompass a whole number of things.
No, that's helpful to know. I just, because obviously being a layman, I don't understand the dental world. Even though I did a year at university in the Birmingham Dental School, but not as a dental student, I care to mention. But you know, in terms of that, would there be an opportunity to say free up dentist time to potentially do the more complex treatments if hygienists were seeing more of the regular checkups that people need to see?
And that is one of the things that since COVID has come in, the use of skill mix and promoting that. It's not just hygienists. There are dental therapists who can do more, so they can do fillings, they can see children, which is why there's access for children in the NHS. Because the dentist doesn't need to see them, the therapist can see them and then refer to the dentist if there's anything complex. So that is a model that practices are using more. There are a lot of over-deceased dentists who haven't managed to get on the GDC register as a dentist, but did manage to get on as a therapist, and they've increased the capacity, which has been very helpful. They're now moving on to be dentists whilst they're going through the system. The problem is that the therapists can't do everything, so you still need dentists there to do more complex stuff like root canal and crowns. And those are all the more difficult things to do and more time consuming. So there can be a little bit, it's a bit complicated as to how that actually financially works for a dentist. If they've got a therapist, they've got to pay to do some stuff, and then there's not much pay left in the kitty for what they're actually doing. But that's a work in progress. You know. Yeah, it's definitely something we're supporting.
No, thank you very much for that. Any other members? Any questions? Councillor Dodds.
Been listening very closely to this. I go to an NHS dentist every 3 months, and I have 2 appointments each time. First appointment I have with a hygienist, and the second appointment I have with a dentist for a checkup. So I've just been listening to how many UDAs that may be. This has been ongoing for a number of years. And I'm at a point now where I'm ready to have some new teeth. So I can go to Turkey and spend £5,000, 2 visits, 2 whole weeks. Yeah, don't go there. Or I can go a mile up the road and spend £20,000. And don't go there, I guess, would be the same answer, wouldn't it, for most people. So why is there such a disparity in that? And the other thing is, if I miss 2 of my appointments, so if I went today, 3 months later I broke the appointment, 3 months later I missed that appointment, they'd remove me from the list, which seems wrong, shall we say, given that I've been going to this dentist for 26 years.
Can I just quickly add to that? I didn't know Councillor Doddy was going to make that point about access to services in Turkey, but anecdotally, I have had employees in the past who've worked for me, EU nationals, who've flown back to their home country, accessed dental services, and flown back again for less than what they can access it in this country. So I think it is quite a pertinent point about where the disparity is in terms of that cost as well. I just thought I'd add a bit more context to that question.
Yeah, it does happen. The other countries, the dentistry mainly, are good. They're just markets in that country means that they don't have to charge so much for it. Even before Turkey became an option, a number of patients I knew used to fly further afield, let's say back home to wherever, because they felt comfortable going there as well. It is not as regulated as dentistry is in this country, and obviously, from my point of view, I can't recommend any dentist to you, whether they're in Turkey or outside. Probably outside in Nottingham, I probably have more knowledge of them, but in Turkey, obviously, I have no. So I would recommend to make your choices carefully and consider the long term. If you seek any treatment outside the NHS doesn't have to fix it. And some of the treatments that they can offer quite cheaply are very, very complex. The basic NHS offer for new teeth is still a set of dentures. And there's no provision for otherwise in there, even if you can't wear dentures, there's very limited availability for that, and it's not in primary care, it would be in one of the dental hospitals, which we don't have and obviously your clinical needs are different to everybody's here, and there are some people who have a clinical need that they do need to see, which I did touch on earlier, that there are some people who need to be seen regularly. And the fact that you need to see the hygienist regularly gives me an idea of what the need is, and that is just a genetic, that 10% of the population are more prone to some things than other people, so it's nobody's fault or nothing you do, it is just life. Seeing the hygienist is beneficial to trying to maintain anyone's oral health if they have these situations. Prior to COVID, you had to see the dentist every time you saw the hygienist to get your UDA, whereas now you can see the hygienist without seeing the dentist, but that's, you can't turn back the clock, can we? I think that, yeah, there is a disparity that things that the NHS contract is quite basic, and there are mandatory services in there which a dentist has to provide. There's other things which sort of sit on these are alternatives that I might prefer or might actually seem better or whatever, but they're not in mandatory services. So I suppose it comes with the contract, which I haven't funded anymore. It'll be a bit unfair to then ask people to provide much more expensive treatment within it as well without extra funding. So again, it's a bigger picture.
So given the time that we're on, unless any members have got burning questions, I'm going to summarise and move to recommendations, if I may. I really thank you for your time this morning. I think all members have recognised just how candid you've been in your responses. You know, you've been very open and provided a lot of information, a lot of clarity there. So we very much thank you for that, because that's one thing that we do appreciate on this committee is the openness and transparency. And yeah, there are some key issues that I think that is out of your control around the sort of central contracts. So it's something that obviously needs lobbying for within government. I would obviously, with a degree of vested interest, obviously ask you to go away and look at that and sort of area need, because I do believe that massive law probably is the anomaly on that one. But I think we're again, committed to go away and looking at that as well. So yes, I can't thank you any more than that. So I do thank you for your time this morning. So I'll now move to the recommendations, which is recommendation 1, that the report be noted. Yeah. And that feedback from members on the dentistry update be noted. There we go. Thank you. So yeah, we thank you for your time, and yeah, we will have a transition over to the next contributors. Thank you very much for attending.
So,
yeah, number of times.
Yeah.
So we'll just wait for the next contributors. So we're going to provide an update on adjusted care for autistic people. So we'll just wait for them to come in.
One question. If you sit in the chair, I was going to ask you, because the vulnerable patients, as I say, as an example, autistic kids, in that case, get that really back all the time. But these are only get one new day. So then came to fund yeah.
Are we all good? So thank you. So we'll move on now to item number 7, which is an item looking at providing adjusted care for autistic people and people with learning disabilities across Nottinghamshire. So we will be getting a report from the integrated care boards across Nottingham and Nottinghamshire, Derby and Derbyshire and Lincolnshire. And I would like to welcome our presenters. So Jan Senzia is a frequent attender, so welcome back, Jan. The Executive Director of Partnerships and Strategy at NHFT. Vicky Romilly, the Medical Director at NHFT. And I will be a bit cautious with this one. Is it V. Rebay? V, okay, lovely, thank you. Who is the Associate Director of Mental Health, Learning, Disability, Autism and Children's Commissioning at Derby and Derbyshire ICB. So I welcome you all this morning, and if I may, could I ask you to introduce your report?
I'm going to hand over to Charlotte, who's going to introduce herself. Charlotte's also from the ICB, and maybe Sharon, you might want to introduce yourself as well. So do you want to start with Sharon? Then Charlotte, you just introduce yourself, Sharon.
Good morning, everybody. Sharon Bramwell. I'm the Operational Manager for Intellectual Development and Disability Services. I was going to say the acronym IDD. And Prescribed Services, I work with Nottingham Healthcare Trust. I'm the Operational Manager.
And I'm Vicky Romilly. I just wanted to clarify, I'm a speech language therapist and consultant in learning disabilities and autism. Thank you. Hello, good morning everybody. So I'm Charlotte Redding and I am Head of Learning Disabilities and Autism Transformation and Commissioning for the ICB, and I'm going to present the paper today, if that's okay. So I'm going to just briefly give you an overview of the paper for around 10 minutes and then open it up for questions and discussion, if that's okay. So just by way of introduction, so as you're all aware, we're here to talk about how is the system across Nottinghamshire we're meeting the needs of autistic people and also individuals with learning disabilities. So we know that we have an Equality Act that places the statutory duty on all organisations to make reasonable adjustments to meet the needs of disabled people. I'm going to kind of split the paper into kind of two halves, if that's okay. So I'm going to talk a little bit about how we identify the needs of autistic people and people with learning disabilities. And then I'm going to go on to talk about how are we actually meeting needs and where we think there may be challenges and where we think there may be gaps. And you'll see there is an action plan at the end where we've identified how we intend to address some of those gaps. So in terms of identifying needs, we do that strategically and on a kind of a wider footprint through a joint strategic needs assessment. So across the system, so across Nottingham and Nottinghamshire, we've developed two JSNAs. So one for autism, which was developed and published last year, and then more recently the Learning Disabilities JSNA, which was agreed at Health and Wellbeing Board in March this year. Both JSNAs have identified that we need to do better at identifying the needs of people with learning disabilities and autistic people, make better use of data, and also ensure that all services are making reasonable adjustments. Additionally, both JSNAs have got a key recommendation around developing a strategy for autistic people and a strategy for learning disabilities. We are further ahead with the autism strategy, which we are co-producing with people with lived experience. So we have a dedicated group that meets monthly to help us to understand what are our key priorities and what are the key areas that we need to work on. The Learning Disability Strategy is due to commence later on this year. So moving then on to how else we meet needs at a more individual level. So I've referenced in the report the Learning Disability Annual Health Check. So everybody with a learning disability who is 14 years and over is invited to their GP to undertake an annual health check. And that's the way in which we can identify any health conditions and also make sure that there is an accompanying health action plan so that we are addressing those health needs. The other key point is that we are expecting an equivalent health check to be implemented for autistic people, but we're not clear on timescales. This is something that NHS England have said that they want to do, but that hasn't yet been put into place. So at the moment, we don't have a health check for autistic people. So that in terms of individual needs, those are some of the ways in which we identify those needs, but I kind of also wanted to talk about services that we have in place as well. So we also understand needs by assessing people. So we have a number of services in place. I'm not going to go through all of them, they are in your paper, but we have what's called specialist services that are delivered by Nottinghamshire Healthcare Trust. And as you know, we've got colleagues here today. And also, all services will have to, in September this year, implement the digital flag. So that will be another way to individually identify needs of people, what reasonable needs to be in place for people, and also that flag will also enable those needs to be communicated amongst services. So if, for example, somebody is receiving the service in, let's say, Nottinghamshire Healthcare Trust, they might be part of the community nursing team, and then they have to go into hospital. The idea is that when that individual has to go into hospital, their needs are already known about. And that is, as I say, that is due to be implemented in September. So just moving on then, in terms of how we're meeting the needs of people with learning disabilities and autistic people. So you will see in the report, I think it's fair to say that we have much more services in place for people with learning disability. We have long-standing services in place. We have a primary care liaison service that works with GPs and the wider healthcare community to make reasonable adjustments and to support with the annual health checks I've mentioned. And we also have an acute liaison service that works within our acute hospital trust. And those services work together so that if somebody does need to go into hospital and they're known to the primary care liaison service and other teams, those services can work together to understand what might need to be put in place to make sure that that experience in hospital is optimal. The other key thing I wanted to touch upon in terms of meeting needs is around the training. So we have training packages that are delivered by our specialist services. However, we also have quite a comprehensive training offer that is mandated across Nottingham and Nottinghamshire. So we have the nationally mandated Oliver McGowan training that seeks to really raise awareness around the needs of people with learning disability and autistic people. It also looks to really train people on how they can make reasonable adjustments. But we also have two other training courses that are not as widely offered because they are attached to some specific funding streams. But we do have the spell training and the Freud training too. And in the report, you will see some feedback from staff in terms of how that training has been received. We know that, as I said earlier, that we've got some gaps. We know that we need to increase the uptake of the training across our system. We know that we need to ensure that people are meeting the needs of autistic people. So when I come onto the action plan, you'll see that there are some actions around how we could look to thinking about how some of our services could possibly expand to meet the needs of autistic people. And I think just before I get on to the action plan, I suppose one thing I really wanted to emphasise is around the kind of the golden thread running through. So everything that we're really trying to do is to ensure that everything we're doing is co-produced. So making sure that the voice of people's lived experience is running through everything that we do. So in terms of the needs assessment mentioned, that incorporated the voices of people with lived experience. The strategy will include voices of people with lived experience, and we make sure that services are receiving feedback. And there is quite a nice case study in the report that I won't go through, that really demonstrates how the needs of people and their communication needs were taken into consideration for that individual when they had to go into hospital. So I wanted to just end really with what we think we need to do. So I think the key thing is around making sure that everybody is adhering to the requirement around the reasonable adjustments digital flag. That can be a key mechanism to identify needs, ensure those are met. As I said, we need to think about how we could have a wider offer for autistic people. And also we know that Nottingham University Hospital Trust have committed to looking at how they're meeting the needs of neurodivergent people. We also know that we've got a gap around blood tests, so individuals with, particularly with learning disabilities, who struggle to have blood tests taken. So while the primary care liaison team will do quite a lot of work around desensitisation, there comes a point where for some people that's still not enough. So how can we make sure that we're able to do that in a least restrictive way as possible, but to make sure that those needs are identified. And then finally, we know that the next stage of the Oliver McGowan training offer, so we've piloted it, we know that the next stage is for providers to develop a more sustainable Oliver McGowan training offer. So I think that is where I'm going to end. If any of my colleagues have got anything they would like to add that I might have missed, I've skipped over that quite quickly. I know it's quite a long report, but if there's anything anybody would like to add. You're very comprehensive. Okay, thank you. So then we'll open to questions. Thank you.
Hey, thank you very much for that report. So would any members like to start? Councillor Barlow?
Yes, good morning, thank you. I noticed you referred to the Oliver McGowan training delivery. Do you think the current pace of that training delivery is sufficient, given that only 21% of the workforce have completed the training?
I think that we see that the training as a cultural change programme, and of course the change takes time, and really well challenge and be able to that training programme to me, seeing it evolve, the national pilots moving into local pilots, demonstrates that this is the heart of significant strategy change. We've talked to you today about specialist services. I think that the fact that we started by talking about the Equality Act and then we're ending thinking about the Oliver McGowan training highlights that we need to start thinking with vulnerable populations. This is everybody's business. The Oliver McGowan training demonstrates that this is everybody's business. However, it is awareness training alone, and we know that in order to enact behaviour change, in order to bring those routine adjustments, we need more than behaviour change. So we recognise the point that we're making about pace, and we are really trying at times of change to think about our system approach. We really believe in terms of behaviour change in cross-fertilisation of thinking. We need staff from NUH to be working alongside staff from healthcare, who are working alongside staff from primary care, who are working in a way, as Charlotte said, that is co-produced. And that type of change takes time, but we recognise the commitment that we've made, and we aspire to think about how we grow a workforce that engages in that nationally mandated code of practice. But also we are equally interested in learning from the new national evaluation that I think has just started, being led by University of Leicester. Because actually what we're interested in is behaviour change in our system. And to enact behaviour change in our system, we recognise that potentially are often long term, and we need to be an awareness course and then grow further in an awareness course.
Morning. So I'm not sure if I missed this step, but I wonder how, obviously we know that we have diagnosed autism and learning disabilities. How are they flagged? When is that first kind of appointment with some kind of medical professional where they are flagged on the system and then that information is taken forward for the adjustment of needs as appropriate?
Thank you. So when somebody is first diagnosed, then it's often what we'd like it to be in childhood. We know that with autism, we're a little bit behind because of, we know that it's being much more widely recognised nowadays than it used to be. So we know that some adults are being diagnosed in adults now. But how it should work is that, generally speaking, a child will be diagnosed usually by a pediatrician. And then what will happen crucially is that they will be on what's called the GP cost register, so the quality outcome framework. So because they're on the GP register, then once they're aged 14, then they'll be automatically invited to the annual health check. As it is at the moment, as I say, autism we're hoping will follow soon. And I think what will now, so that's how it's currently working, but from September, what all providers will need to do is make sure that they're using the reasonable adjustments digital flag. So it will mean that once somebody's needs are identified, then all health services and all social care services will be able to read what's written there and be able to then understand what reasonable adjustments need to be made. But we're not there yet. So at the moment we are working with our providers to make sure that all of their systems are geared up to be able to actually use it so that people are able to use the flag and then to be able to share it. So and I think it's fair to say that providers are in a different place, but we are working with providers to understand in terms of how far away they are in terms of being able to use the flag. So I know that Notts Healthcare Trust have been doing lots of work around their clinical system, and I think it's probably fair to say that Health are a little bit further ahead with it because it started out just with how social care came on a bit later. I think Jan might want to come in, so I will.
All I was going to add was I think you were talking about the point of referral, and I think children, that can be parents, schools, it can be, you know, that's where the referral first come. Adults, it's generally speaking self-referral, but it may be flagged by other health professionals, and in Notts Healthcare's experience, obviously because we're a mental health trust, we would have people presenting to us with mental illness, but we may also that may be underlying autism or learning disability there, in which case we may refer them through those means as well. But generally speaking, it's not self-referral, and I don't think I'm right in saying so. We want to come and be.
Yeah, just very briefly, we're also trying to move away from doing the assessments, but also supporting children early in schools with educational psychology involved, also at our neighbourhood level as well, so that we can actually start to support more resilience for people as well, and that support is really important. I know diagnosis can be really important too, but it's often what we can do afterwards, how we can support people in daily life is difficult. We just have to focus that piece as well, which is what we are moving on to.
So when you have like just training, is the aim to have all medical professionals in all departments of everything that anyone might have to go to the doctors or hospital for training so that they can appropriately treat people?
Yes, that is the idea, and that is why all clinical systems have been amended to be able to utilise that flag. So it's been added to all clinical systems. And as I say, that it's been a real work in progress. So there's been a lot of work done with the actual system providers themselves to get them ready for this, for implementation in September. But yes, that is the idea.
I was just going to ask about digital flag. I think it's really good, and I'd like to know what the process is for knowing it's actually being used. Is there an audit trail, or is there a way that you're able to track this usage and know whether or not that's actually
So I don't inside doing the applicant answer question. So right now, NHS England are mandating that that is ready by September 2026.
We have a sister meeting that is convened by our SME cluster colleagues to bring providers together to think about our developments. In our most recent meeting, we had a really robust conversation about how we're building systems. So we need to build in our systems a plan. We need to build a way of recognising in the long term, and we were using to this, we need to build a way of supporting workforce to be able to access with ease tools that support reasonable adjustments. We're at an early stage of being able to do that right now. I think we're moving at a pace where we will be ready to start to pilot the system. And I think has provided to us with the reporting back into our ICB, back into our cluster. And I think in terms of your question, you then need to think about how we evaluate. Because actually, when we evaluate behaviour change, I like thinking about the passive model, that we are not just thinking about awareness raising. Because if we're just thinking about awareness training raising, we will not enact behaviour change. So we need to come gradually to think about behaviour change, and we need to be able to understand what changes at doing that individual level. And I think the previous question too helps us to be mindful of thinking with the individual population-based level. So just to be clear and answering your question, September 2026, we need to be ready, and the questions that arise and Alex to us about how do we then that.
And just to add to that, Sabrina, I think we absolutely need to be led by patients like that. And so I'm assuming that the digital flag, that patients will know that they've got a digital flag, that we need to be very transparent, and they will to some extent monitor how well we're doing at enacting that digital flag. And I think we need to really work with patients to understand how is it working for them. That's, I think we can do the reporting upwards, but really who we're accountable to is the patients.
Yeah, 100%. I think that's what I was getting to. It's like the end user and understanding what the digital flag, like all the flags in the world, that the users, the receivers of that, and aren't telling us it's working for them. We need to be able to create that flag to not trying to avoid process.
Councillor Rich.
Hiya, thank you, Chair. So I've got an autistic child myself, so I've got a bit of an idea of what's going on. So autistic kids don't like changes. They're a bit concerned about when changes come along. Well, on page 34, on paragraph 3.3, paragraph 3, second paragraph, sorry. How's the Commission plan to tackle high staff turnover and operation demands that are currently limited to staff attendance? You know how autistic is, when seeing with people, they're going to act differently, they're going to behave differently, and you know what, it's going to be the hardest to control.
I think that my understanding of autism through lived experience in my professional work is about creating certainty and creating predictability. Lots of the worlds that we operate in are not certain and not predictable. Quite often I'm involved in thinking about scope and change, and I'm delighted to hear people on the front line talk about their recognition of the need to find certainty as a team. So I'm not sure that my comments absolutely reassure you, but I hear your viewpoint, and I think that I feel really proud of the job strategic needs assessment that we have developed that highlights a neuro-affirmative approach, which actually needs not only belong to statutory care, but needs to belong to us as Nottinghamshire together. So thank you for your comment. I don't know if anything more can be said.
Just want to affirm that as well, and really what we need to move towards is actually how can we apply this as a society as well. Reasonable adjustments, it could for other people as well. and clearly offering that structure is helpful for people. It's knowing that and being able to implement that at every level to almost make it from the niche into mainstream of viewers and services. I've certainly seen the awareness raised a huge amount in the years I've been in the NHS as well, so it's a real opportunity to work together as organisations to really make this happen for people. Particularly for children, and I listen across the board, but there's a lot of work is going to happen in schools as well, in supporting children. I'm a governor in another role outside of work, and I can see the impact of children in mainstream schools as well, and what changes that happening in that space as well. So I recognise we've got a really good system, alliance as well, that brings organisations together to really make sure that we keep this at the heart as well.
And just an observation from me is that I think many of the reasonable adjustments that have been made, actually, they certainly support people living with autism, living with an learning disability. But actually, when you think about the things you just talked about in terms of consistency and structure, most of us want that, and most of us react better to that. So I think using the reasonable adjustments in a way that we described to help really impact on how we deliver services generally is a really good thing. And I think that's what we're trying to do, is trying to get that embedded, that thinking embedded. It's kind of something that we really take to heart and think about those reasonable adjustments in a general way, as well as the specific things. Then I think we can really make some cultural changes that we talked about.
I think just one thing to add to that as well, with the initial intention when our primary care nurses and liaison nurses were introduced, they were role modelling and trying to support with that whole mainstreaming of reasonable adjustments. And I think throughout the primary care networks, how they operate and within our acute hospitals, they're very respected, and we're finding that people are reaching out to them and saying, actually, we need this learning, we need to be able to understand what reasonable adjustments are needed. I've seen myself over the last 6.5 years working not on pensions, but the acute staff will actually reach out and say, we've got somebody that's coming onto our ward, even though our acute liaison nurses get a daily update about with a learning disability or with autism that might be coming onto their wards, they are reaching out in advance to say, what do we need to do? How do we make this an environment that is going to be sensory in the right position for an individual to be able to come in? So it's a slow change, and obviously as we have new staff that are coming in, we are wanting to ensure that it's a cultural thing, it's a cultural way of operating rather than being just about awareness. It is about, this is the way we operate. So I do think that they've achieved a lot in terms of being primary care liaison nurses, acute liaison nurses. There's something, and what we now need to see is the organisations taking on that responsibility and then supporting them to do that better.
Okay, Councillor Vernon.
It's almost an observation. I support a group of children in a specialist nursery for autism. I knew nothing at all about the subject whatsoever. And I invited all the mothers in and sat them all down. I said, if you could change something, what would it be? Bear in mind that these are nursery age. Early diagnosis. They didn't know where to go, how to go there. GPs weren't really clued up on it. And one lady, I said, how long before you got your diagnosis? 10 years. I couldn't believe it. So is there anything I can take back to that nursery today?
Thank you for that observation. We are seeing that nationally, regionally, and locally as well. We are seeing a shift in our approach as well. It's something we really want to look at in the future. There's still a lot of work to be done. Really, but there is a real shift to actually move our intervention more to early years. We can support them at early years. You're absolutely right. Starts before school even, and how we can support children in that space. We have got long waits, and we are we are starting to tackle those as well, and that's a real commitment from ICB and ICB plus the point of view as well. Then we don't need that. But even more importantly is how we can support schools and nurseries as well, and offer that support early doors. Even without diagnosis, there's an opportunity there to support children. So that's a really good point, well made, and it's certainly part of our strategy moving forward.
Thank you. And just to add to that, so the priorities that you have just outlined and that you spoke to are the same as the ones that have been highlighted by our individuals with lived experience as part of the autism strategy work. So we have a lot of families who are working with us on behalf of their children and telling us that yes, early diagnosis and early, as we have mentioned, early needs support as well. So as we've said, diagnosis is one thing, but how are we meeting needs at an early stage? So just to assure you that is one of the priorities that will be in the strategy. And we aren't happy with the long waits. I don't think we're happy locally. We know that we aren't happy nationally. We know this is a national problem. And so there is a government commitment to refresh the autism strategy because that actually ends next month, so July. So we know that there is government commitment to refresh, and we know that there is lots of work being done nationally to think about how do we meet needs earlier and how these interventions. So just to assure you that those that have been mentioned by the people we spoke to are that what we are going to.
And the other thing that came out of this group, support from the parents. As a newborn, they see signs, they think they see signs, they're worried sick, they don't know who to go to, where to go to. We have a lot of drop-in centres that aren't being used. And all of those mothers said they would volunteer and go along, meet with all the mothers, pass on their experience, etc. Could we coordinate that maybe centrally? Thank you.
Yes, so yes, again, support for families has been highlighted as well. We know we've got a carer strategy, but how are we making sure that that carer strategy meets the needs of carers of autistic children and children with learning disabilities? So we are, that's another piece of work actually that the local authorities are undertaking so that they can really understand how that strategy and implementation plan is meeting those particular needs. And again, there will be read across to the autism strategy as well. I think you make a very good point.
Oh yeah, so now go on with please.
Thank you. If I can add a couple of points to your question. There's a piece of work that we've undertaken in Nottinghamshire Healthcare Trust with a national charity called the Human Factors Group. The Human Factors Group helps us to think about issues related to safety and patient safety. This relates to adulthood, but I think it's important in terms of your question. We have the same longer waits in adulthood for diagnosis. In our work with the Human Factors Group, that's really leading us to think about how can we work in a system that is needs-led and not necessarily diagnostic-led. What are people's needs at the point of trying to access support and care? What resource can we put into adapting services, which really relates to some of the questions that we were asked earlier as well? And how do we ensure that recent adjustments fit across Nottinghamshire and we develop an autism-friendly Nottinghamshire? How that then links into, we have to respond to national policy, we have to deliver services according to national policy. We're really proud to belong to a group called the Nottinghamshire Neurodiversity Network. The Nottinghamshire Neurodiversity Network is led by university partners, but many of us here are part of their core steering group. Something really important about how research aligns to people's experience, which then aligns to policy. And we're excited about how we grow that group. We're trying hard at the moment to financially sustain that group for another couple of years. The most recent output from that group is a visual tree of support. So recognising that families find it hard to access support in one place. So our colleagues at the university have led in a very used way
a simple tree diagram of support with QR codes to take people to different places of support. So when that's finalised, we would be happy to share that. And that's just an example of us working across the system together, which is likened to the work that Charlotte has led and commissioned around the Minds of Clients website. Minds of Clients website is a really incredible resource for people in Nottinghamshire to think about support for families alongside wider support groups too.
Fantastic, thank you very much.
Councillor Helen.
Yes, thank you. The report demonstrates obviously a considerable commitment from health services to improving the care for autistic people and people with learning disabilities. One of the most striking findings is that dedicated specialist support remains considerably stronger for people with learning disabilities than autistic people. Why is this, and how will the success be measured when the new autism and learning disability strategies are implemented?
Yes, thank you. And I think that's a really good question. And I think the reason for that is because the models that we developed were nationally mandated. So the primary care liaison service and the acute liaison service were nationally mandated models across the country for people with learning disabilities. But I am going back. They commenced around 2009, 2010. We've obviously grown quite a bit since then. So I think that's why we are committed to making sure that we're looking at those services and thinking about, well, how can we meet the needs? And I think the reason why things have evolved the way they have is because I think there is a much greater understanding of the needs of people with learning disabilities. We have some key national, very well publicised policies and strategies for learning disability. So we have valuing people, then we have valuing people now, key government managed documents that really underpins the policy developments and the service developments. I think with autism, we've had the autism strategy, but there's almost been a kind of a change in strategy by saying, well, we should be making sure that all services meet the needs of autistic people, rather than having the dedicated specialist services. And that, I think, is the difference. So I think for us, it's about as a system, how do we balance the need for, we know that we do need some specialist services, but how do we make sure that we really widen that reach so that all services are meeting the needs of autistic people? And I think that's the balance, and that's the challenge, which is why we really want to look at some of our specialist services to understand whether or not we can expand them, and so that they are able to meet the needs of autistic people. So that does that answer your question? Thank you.
Okay, so there's no other members of right, okay. As always, I always like to keep myself till last. So I'll just pick up on a point that's just been made there about the need for specialist services, some specialist services. But in March 2026, we lost Bassett Law Children's Learning Disability Services. They were cut. So how is it that we have a need for specialist services, but in Bassett Law, we had our specialist services cut?
So I can talk a little bit about this, although it's not my specific area. So apologies if it's not as comprehensive an answer as you might like. But my understanding is that the reason that happened was because there was duplication. So it was felt that there were other services that were undertaking similar roles in Bassett Law. So that is my understanding as to why, because obviously at a time when we've got very challenged systems, very financially challenged systems, it was felt that by having an evaluation of how services, what those services were doing and what other services were doing, my understanding is there was some duplication, which is why that particular service was caught. However, I am conscious it is not my area, so I only know some of that, so I am happy, if that's okay with you, if I go back and get a bit more detail around the decision and a bit more of a complex answer for you, if that's okay.
Yeah, please, if you would. Appreciate that.
Just going to say that, Charlotte, this is an adult hospital, isn't it? But we won't have to do really Adegoke and get back to you. Thank you.
Yeah, the reason I ask is I've looked into this in detail because I'm a Bassett councillor, so vested interest and all. But the duplication didn't seem to be in Bassett, or it seemed to be in Nottinghamshire. And a lot of the signposted services now are for places in Kirkby and Ashfield or Mansfield. Now, if you live in my part of Bassett, you've got 2 bus journeys to get to Worksop, let alone get some of these services wider in the county. Now, if you think about people with young people, especially with learning difficulties or with autism. Now, I have a 5-year-old, which we suspect will be diagnosed with autism, very unique in some of his traits. If I was to take a number of bus journeys to access a service, just imagine what it'd be like at the end of that bus journey before he's even got the care. So, you know, this is where I think, you know, we miss a trick because we're almost like locating services too far away for people to access.
Thank you, Chair. A really good point. I think we've also got a really great opportunity with our neighbourhoods as well that are taking off and already are doing some really good work where we are really where we can provide care closer to home. We should, so that is an opportunity as well. There's in the, and I know it's an adult hospital, in the children's space there are certainly developments in the neighbourhoods team space that will support children a bit more in their localities and communities as well. At the start in life, and then the family hubs as well, which will be opportunities where we can, again, like other councillors have said, can start to link up some of these services and maybe go out to people and support people more in their communities as well. So it's a real opportunity to see that neighbourhood model develop, and there's specifics on children. You know, it's not necessarily part of the brief this morning, but we can give some further feedback on that as well.
Yeah, I appreciate that. I know that there's obviously going to be a lot of changes coming to the services through the 10-year plan and bringing things more into neighbourhoods. And if you're boring enough to watch the re-rules of the previous meetings, I have quite an interest in the term neighbourhood, community and everything else, because it's still not been defined. And what I consider it compared to other things is not for now, I would say. But one of the things I would like to touch on is, and we've looked at the development of strategies, one for autism and one for learning disabilities, onto the JSNA, another pet thing of mine. So the JSNA, I've looked in detail at the JSNA and chapters that have been published, and we have things on there that are 10, 12 years on there, and the problem's still there. So, you know, why have we waited so long to bring these strategies onto the JSNA? And instead of us talking about this may happen in the future, it's all aspirational, neighbourhood plan, blah, blah, blah. Have we got any targeted delivery dates for actually, you know, delivering some of these you know, sort of services that we want to assist, you know, adjusted care for people with autism and learning disability?
So, as you said, we've got a lot of change currently, particularly in the NHS, but also in local authority as well. So we are really bringing our plans together at the moment and using JSNAs to be informed about strategic direction. And we will continue to do that. Those will happen at strategic commissioning level, but also at neighbourhood team level. So we will continue to engage on those models. And there's some real specifics in the neighbourhood team models that will address some of these issues that we have raised as well. There will be timescales to that as well. We're not able to give you those yet, but they are in development.
And if I can just add that when we develop the strategy, there will be an implementation plan. Exactly what we did. So this won't be the first time we've developed a strategy. We had a previous strategy, and if I'm honest, we were very ambitious. We had about 10 to 12 high-level actions, and then quite a number of sub-actions underneath that. And I think we recognised that we were too ambitious. And although it's lovely to be ambitious, we need to be realistic and make sure that our population are helping us to decide, okay, so what are our key priorities that we know we want to achieve, and then what is the action plan that sits behind it with some clear timescales. And actually, the people we're working with to co-produce a strategy will continue to be involved and will hold us to account in terms of those timescales. They've already asked us quite clearly, where is the accountability? So once we develop the strategy,
where will it sit? What will happen? It doesn't get delivered. So they're already asking those questions, quite rightly. So we will be very happy to share once we've developed the strategy and the implementation plan, so that you've got a much clearer idea of timescales.
Okay, thank you for that. A few more questions. So I know we've touched on the Oldham and Gowan training a fair bit today. But one thing I'm conscious of, especially with my son and his care, we've been fortunate or maybe unfortunate, I don't know which way to look at it, but we've been under the care of Great Ormond Street and also Sheffield Children's Hospital. And you see a lot of the good work that goes on in those settings to ease the journey for patients who are stressed by quite stressful environments. I don't like hospitals, to be fair, so understanding how people with autism may, deal with that. So what are you doing around sort of reviewing the environmental effects of, people attending hospital, and what changes might you wish to make in that respect?
So, if I start by talking to you about resources that have been made available to us through NHS England in the last couple of years, so I'm really clear that does relate to mental health care. I think it's important because I think it shows a journey of growth and change of where we can get to. And actually, some of that learning we're already seeing within our acute care hospitals too. So we've been able to, for short-term periods of time, employ people with expert skill sets in thinking about sensory. And when you understand autism, whether from a professional viewpoint or from a family viewpoint, you understand that sensory is absolutely paramount. You need to think about sensory before we think about other things. And your examples, I often give people examples of accepting personal bugs as well. We need to think about both the planning, the sequencing, the sensory experience that people have. So within our hospital environments, within our psychiatric environments, we've been able to offer some intensive training to our workforce to understand the world from a sensory point of view, get to a point where they can develop, and some of these tools are available for free. They can develop sensory ladders, sensory spiders to understand the autistic person and to develop with an autistic person, understand their sensory experience. Very recently, through capital funds, we've been able to secure funds to help us think about our sensory environment. So I think that's the most visual, our psychiatric hospital in Mansfield, where we've developed a sensory garden. And it's a pleasure, actually, to see people sitting in confidential pods where they're engaging in therapeutic work out alongside nature. So the changes that we've been able to make with equipment and changes that we've been able to make in terms of workforce. Equally, there have been changes that we've been able to make that are about the start of somebody's journey in healthcare. So if somebody's referred into us, what I'm starting to see now in my role is the occupational therapists are starting to say their team, we need to do a sensory checklist first. So actually that wasn't our norm a few years ago, and that's becoming our norm now, and that's changing. And we've seen, I think, within NUH, as an example, there's been a lovely piece of work that's happened around supporting people with sensory bags. So actually, if you're expecting somebody to come to a very busy environment, how can somebody self-soothe? How can somebody self-regulate? And using sensory bags and sensory toys can do that. I don't know if Sharon wants to say any more about that than I do.
I suppose the strongest thing to say about that is that idea of going outside the person with autism that came and said, actually, this is something that worked for me. And so they brought it to the acute liaison nursing team. Unfortunately, they were able to access that charitable funds to be able to develop it and implement it. And it's not purely being implemented for people on a one-to-one basis. It's being used in our accident and emergency rooms. So I think that's really useful and demonstrating one co-production, responding to need, and as we keep saying, being diagnosed is one thing, it really serves a purpose, but understanding people at their point of need and then being able to, I like to call it the social model of disability, which is about giving the individual the voice to be able to say, this is my needs, this is how I need you to be able to change. And I think those sensory rights are a start of saying to the individual, you have a right and to be able to explain and express these are your needs. And I think the case study that's involved, that's included as well, articulates some of that really well.
Thank you very much for that. I think that I may have not picked this up in the report, but just thinking about the element pre-hospital, because I couldn't see anything about pre-hospital care for people with autism and learning disabilities before they actually get to the point of hospital care. So is there any provision for that, you know, sort of building them towards the journey of going into the healthcare setting?
I think, unfortunately, we have to admit that there is a gap in services and that our acute liaison nurses and primary care liaison nurses are commissioned to deliver a service for people with learning disabilities. I think on the point was made earlier about why is the pace being so different, you know, learning disabilities so far ahead. However, what we're hoping and what I think, like I said before, is that our acute liaison nurses, the NUH staff, all the city hospital staff, if they can see that they've got somebody that's coming into hospital that needs their information to be adjusted, then they will ask for our speech and language therapists to be engaged and involved with making the information accessible for the individual. And I think one of the main things that we have, like I said before, is asking what are your needs, what do you need to be able to come into hospital? And it's mainstream services that need to answer those questions so that our acute liaison nurses, where possible, are able to provide some of that advice, rather than, because we're not commissioned at the moment to deliver that. Is there anything about any aspirations? Well, I think it's important.
Is it still an issue? Maybe. So I can.
So coming back to some of our earlier points, some of the earlier questions from you, what is specialist and what is reasonable? And if we are going to move towards a reasonable adjustment flag, we need this to be owned by us in Nottinghamshire together. And so there may be a gap, but we at the moment look at a gap in the unified specialism. I think what we aspire to do long term is to think about what exists and who can support. And I think that's how the McGowan training is a starting point of that cultural change. But I think about a recent example that I've heard from one of our primary care liaison nurses. A primary care liaison nurse did the specialism that Little, it was a social prescriber who supported the person with a learning disability to prepare for, to get ready for their engagement in acute care services. So I think there's something about where we see gaps, we start to think differently, and we start to think, as you highlighted, in our neighbours and our PCNs, that need to be differently. And I know there's some really lovely examples actually around PCNs level of people employing learning disability nurses directly to think about that neighbourhood, to think about that community.
I think I'm probably out of questions now. So the Councillor Wheeler.
Yeah, thanks. So it's a quick point. I mean, I think over the years, I've been really thankful to have a lot of people with autism and learning disabilities work for me in various settings. And actually, you know, in terms of the right communication, right training, and the resources in place, a fantastic contribution to all this since I've had. And it's a great example of County Council put part in Boots. Hopefully, members are aware in terms of County Council, what we do with allowing members of the public to come to a fantastic cafe and facility in Liverpool, around the Gordon House, and allowing the fact that it allows them work and see the fantastic work that people there who look after and contribute there. And you know, the sales tactic, I mean, I went for 1K and ended up with 6. I wasn't able to find 6. It was great. I need to employ that particular chap that I get back into the working right again. That's how you make a lot of money. But it's just know what work we're doing with employers to show that people with learning difficulties not to come away from having to contribute to their business, because you know, especially at the moment where it's tough with business, you know, in terms of hiring there, we know they're hiring less young people now because it's not financially incentivized to do it and do that extra training there. So my worry is that less people who need that extra support and training taken on because of that pressure on the workforce and business that effectively not have time to do training development to get there. So what work are you doing in talking to government for more incentives for businesses to actually get that support? Thank you.
So we know that in the JSNA, both local authorities and people need to do more work around employment. So that is one of the priorities within the JSNA in terms of making sure that we are doing more work with employers, so making sure that employers are able to make those reasonable payments. So thinking about autistic people, I know one of the recommendations nationally is around being able to assess the needs, as we've said, not necessarily about the focusing on the diagnosis, but what are the needs in the workplace. So what we're thinking about is how can we make sure that we've got services here where we could maybe do more of that kind of functional assessment to identify what some of the needs in the workplace, so that that individual can go to their workplace and say, well, I need this. And then what wraps around that is then the work that the local authorities are doing with employers to make sure that they're able to make those needs. So I think we're trying to tackle it at 2 levels. One at a very individual level, so that people have got something to go to their employer with in terms of reasonable business, and then the other side around what local authorities are doing with employers to make sure they're better aware and able to meet those needs.
Well, I was just going to add about the individual placement service, which is a fantastic service, both in primary care and in mental health. As a trust, we have a really great individual placement service, and that is a service which offers additional help to people to help prepare them for work, to help them think about what kind of work they want to do, to help them apply, and actually, and my background is in employment, what I really love about the service is that it also helps people prepare not just for getting a job, but then for starting work well. And I have been fortunate of accompanying one of their meetings with the client. The client has secured a job with a large employer in Nottingham, and the advisor walks them through every step of the way. So what are you going to do in the first day? What do you need to prepare? How are you going to take that forward? How are you going to have your lunch? All of that kind of stuff. It's brilliant to make sure that that person can make a real success of that job. Whilst at the moment that service is funded from government, mainly to certainly now to help with mental illness, I think there's national recommendations through to extend that service to people with autism and disability. I think that would be a real win. And obviously those advice work with the employers as well, so that the employers know what kind of adjustments they can be helped to make. And the other service that we have that I just wanted to highlight is the Nottingham Recovery College. The Nottingham Recovery College runs like a college, and it runs courses. It has perspectives like a college would. It's linked with Nottingham College, and one of the courses they run is Living Well with Autism. And again, I was very fortunate to sit in one of their classes. And all of the tutors are people with lived experience. So the person who runs the class on Living Well with Autism, somebody who lives with autism themselves and has children with autism. And it's all about how to ask for reasonable adjustments, how to work out what reasonable adjustments you need to make, how to make reasonable adjustments in your own life, so you think about how you manage your own life, how to manage them with other people, and how to take responsibility for that within your life. And it's brilliant. And so coupled together, you think about that extra help that the IPS service can give, along with attending a course like Living Well with Autism, think there is some really great help that you can access. What we need to do is make sure we put pieces together for people so that they can have that. And that will also be helping work with employers as well. As I say, my background's in employment, so I'm absolutely, great to hear what you said. And I think there's so much that can be done in that. Thank you.
Okay, well, if there's no more, I'm conscious of time because I'm terrible at timekeeping. I will move to summarise and then move to the recommendation if I may. Really good presentation this morning. I thank you for that because it's a very big and very challenging topic. I understand it, and I've seen it, and I've got friends and colleagues who've also experienced it over a number of years. So it is a challenging thing, especially when there's so many diverse elements to consider as well. So thank you for coming and presenting that today and answering the questions. I would appreciate if you do feedback about the children's services in Bassett Law. So it's a key one. I know that kind of went under the radar when it was implemented. It didn't come to scrutiny. So I will also say that I would like to invite you back at some point. Obviously, when you've made some progress against the strategies within the JSNA, because I am starting to take a bit of a more hawkish approach to what's on the JSNA to make sure that people are on track with delivering, to timescales. So I will invite you back at the right timescales, not next week. So no pressure on you there. So yeah, thank you for that this morning. So I'll just move to the recommendations for members. So move to recommendation 1 that the report be noted. Thank you. And that feedback of members regarding adjusted care across Nottinghamshire be noted. Thank you. Okay, so thank you very much for that.
Thank you.
We are just going to move on to our work programme item. So if you want to leave, then please feel free to do so. Well, thank you for this morning. So for members, we'll just move very quickly to item 8, which is the work programme. Now, as you all know, it's not really a main highlight, I would say, but we all met yesterday to plan the work programme for 26-27. So obviously the ideas that were put down yesterday, myself, Catherine and Councillor Vernon as Vice Chair will go away and start to develop that into a coherent plan for the coming year. What I would say is that there were some really good ideas coming forward, and I know Councillor Wheeler, you brought some thoughts around things that may want to come off the work programme as well. So when this item does appear on future agendas, I would like to make more use of this to discuss what members actually want to bring forward for the next sessions of the work programme. So I will say that's something I'm keen to do. So I'll very quickly move to the recommendations, which is that the work programme and scrutiny priorities be noted, and that authority be delegated to the health scrutiny lead to update the work programme as appropriate in consultation with myself as Chair and Councillor Vernon as Vice Chair and representatives of the relevant partner organisations, with any changes reported at the next meeting and discussed. Yeah. I think everybody else is now gone. So all I would say is thank you for this morning. I think it's been one of the best committee meetings that we've had under my chairmanship. I thought especially the dentistry one was some fantastic questions and fantastic responses. So I thank you all as always for your contributions, especially those that have substituted for those that have given apologies. And I will therefore call the meeting to a close and request that the broadcasting is stopped. Thank you.
Thank you.
Thank you, Chair.